fourth webinar. Welcome to the webinar series. Today we are going to discuss about colorectal cancer. Actually, as a lone case, it is a very important topic that we have to discuss. Today our speaker is Dr. Vidu Silva. He's a department head and senior lecturer in surgery, Ruhuna University. I think he's the well-known person for management of colorectal cancer in that part of the country. I think that because he's a leading surgeon, I invited him. Actually, he accepted my invitation, and I like to ask him to start his presentation. Vidu.
Okay, so good evening to everybody, and sorry to say good evening at this moment, but there is no other way. And thank you very much for your kind words and giving me a huge introduction, which I did not expect. So shall we start with our basic topics? Can everybody hear me?
Yes, Vidu, we can hear.
Yeah. Okay, right. I just want to share some slides, and I have two options. Either you can just present a case where we can discuss, or I can just start my. Oh, I can start the discussion straight away from my end.
If you have a case history, I think it is better to present right now.
Excuse me, sir. I have a history, sir.
Yeah. Yeah, that's right. Go ahead.
Am I audible, sir?
Yeah, sure. I can hear you.
Sir, good evening, sir. This is the clinical history of W.M. Premaratna, 50-year-old male, who is a farmer profession and a father of 4 children, presented colorectal bleeding and altered bowel habits for 10 months duration. Mr. Premaratna, who is an ex-smoker and a chronic alcohol consumer, and was apparently well until 10 months ago without any comorbidities. He experienced rectal bleeding, which was in nature, and the blood.
I can hear you. Yes.
Sorry.
No, I can hear you. You go ahead, please.
Mr. Premaratna is an ex-smoker and a chronic alcohol consumer and was apparently well until 10 months ago without any comorbidities. Patient experienced rectal bleeding, which was painless in nature, and the blood was mixed with stools. And it was fresh or bright red in color according to the patient. Along with that, he has experienced mucus discharge as well. In addition, he experienced significant lower rectal symptoms, including distressing straining to empty the bowels without resultant evacuation, and also sense of incomplete evacuation. But he denies history of incontinence, fecal soiling, or spurious diarrhea. And patient also experienced that his bowel habits are getting altered by means of consistency, shape, since the consistency and the shape since last 10 months. And in the pre-morbid period, he passes stools 2 times per day with normal consistency. But since the last 10 months, the consistency became constipated prominently, and also noted his stools becoming elongated. Along with that, he has also experienced on and off colicky type of low abdominal pain, specifically in the suprapubic region. There's no history of lump at anus, and there's no pain during defecation. There's no history of extra-intestinal manifestations of inflammatory bowel disease, such as joint pain, painful red eye, roller ulcers, or fever. And also denies history of bleeding from other sides, so history of using anticoagulants or antiplatelets. And also there's no history of past history of tuberculosis, and also history of exposure to TB. And also He denies history of acute onset colic abdominal pain with abdominal distension and vomiting, suggestive of intestinal obstruction. And also he denies history of exertional dyspnea, exertional angina, and lethargy and weakness. Also, the patient does not complain of any fecal urea, pneumaturia, or recurrent urinary tract infections, but he complains of voiding type of lower urinary tract symptoms for the last 8 months. Also, there's no history of back pain, bilateral lower limb numbness or impotency, and also no history of flank pain. Along with these symptoms, patient has experienced that loosening of his clothes and also loss of appetite for all kinds of food. And but although there's loss of weight, there's no subjective measurement of weight loss. No right hypochondrial pain, jaundice, no history of new onset seizures or early morning headache, no history of hemoptysis or cough, no history of intractable back pain or pathological recent fractures. Up to now, patient has not undergone any imaging studies or any invasive procedures like lower GI endoscopy or chemoradiotherapies or special hematological investigations. On past medical history, sir, he has no comorbidities, has been screened for diabetes mellitus, hypertension 6 months back, which was negative, and there's no history of coagulopathies. Surgical history is not significant. No history of abdominal surgeries or rectal surgeries being performed. No history of hemorrhoids. On drug history, is not on any long-term medications like anticoagulants, antiplatelets, or NSAIDs. No allergies for food, drugs, plasters, or contrast. On family history, there's a significant first-degree family history of his elder sister who was being diagnosed with colonic carcinoma at the age of 58 years, who was received surgical treatment. He's unaware regarding the adjuvant treatment or genetic testings being performed and passed away after 3 years of surgery. And also, there's a second-degree family history of breast carcinoma. His paternal aunt was diagnosed of breast carcinoma at the age of at 60s, and mastectomy was being done. On social history, Mr. Premaratne is a farmer by profession, lives in Dodamgaslanda with his family, including wife and 4 children who are healthy otherwise. He usually consumes a normal Sri Lankan diet with adequate amount of fibers and denies consuming large amount of red meat. On habits, he's a chronic alcohol consumer for the last 20 years, but denies history of consuming toddy. And he also a chronic smoker since the age of 20 years with a practice of 10, and currently abstained from smoking for 1 month. He's not educated, he's educated up to O levels, but currently at the time of history taking, he's not being educated on the stomach care. According to the patient, he's able to climb 2 stairs without getting dizzy and able to carry out his farming activities up to now. Regarding ideas and concerns and expectations, he is concerned about the diagnosis, whether it is a malignancy or not, and willing to go for curative surgery. On examination, sir, he looked cachectic. BMI is 19 kilograms per square meter. There's mild pallor, but he's non-icteric. No extra intestinal manifestations of inflammatory bowel disease like erythema nodosum, pyedoma gangrenosum, or uveitis. The oral hygiene is satisfactory. There are no oral pigmentations or oral ulcers. Cervical lymphadenopathy, there's no cervical lymphadenopathy, no peripheral edema. There are no chemoradiation marks, and there's no peripheral stigmata of chronic liver cell disease, although it's a chronic alcohol consumer. On abdominal examination, the abdomen is not distended, no surgical scars, no hepatosplenomegaly or palatable kidneys, no free fluids. On digital rectal examination, there are no piles, fistula openings noted in the perineal area, no skin excoriation, no fecal soiling. On advance in the fingers, I felt a lesion 8 centimeters from the anal verge in the anterior wall, had a ill-defined margins with irregular surface, and the superior border of the lesion was not reachable, and it was immobile or fixed. He had a normal external internal sphincter tone, and there was no contact bleeding. On respiratory system examination, there was no features of pleural effusion. Cardiovascular wise, he's having a blood pressure of 130 by 85 and a pulse rate of 75. And cranial CNS examination was unremarkable. There was no spinal tenderness. On summary, the 50-year-old male patient with a MET score of more than 4 and a ASA1, who is an ex-smoker and a chronic alcohol consumer, presented with non-painful perirectal bleeding and altered bowel habits for 10 months, along with several lower rectal symptoms, including tenesmus. He also complains of voiding-type lower urine tract symptoms, but denies any other history of local or systemic metastatic features except loss of weight and loss of appetite, and has a family history of colonic carcinoma and breast carcinoma. On examination, he was found to have low BMI and mild pallor without any extraintestinal manifestation of inflammatory bowel disease or organ involvement. On DRE revealed an irregular non-mobile lesion in the anterior wall 8 centimeters from the anal verge with preserved sphincter function. That's all.
All right. I think it's a very concise history and the examination. So my intention is to basically discuss which is more relevant for your long case and short. Long case basically it's concise of history taking and the discussion. So in history taking, if a patient comes with a painless or a painful perirectal bleeding, how do we think about what would be your mindset? So in that instance, if a patient is presenting the perirectal bleeding, first mindset would be whether it's a problem with the bleeding disorder or it's a manifestation of bleeding disorder. So in that instance, if you can just exclude the other manifestation of bleeding at the initial stage, where you can guide your history for the alimentary tract symptoms thereafter. For an example, this 50-year-old gentleman presented with perirectal bleeding without any history of a melena or without any history of hemoptysis or without any history of hematuria. Basically, you can guide your examiner. Look, guys, this is something related to the bowel itself, not the generalized manifestation of bleeding. So that would be an initial statement in the history, would be more fashionable rather than just directly discussing about the alimentary symptoms. So since the patient is having a perirectal bleeding which is painless, so where would be the possible pathology? What would be your mindset again? So next step is to find out whether this bleeding, whether it is coming from the upper GI or whether it is coming from the lower GI. Very rarely the upper GI bleeding, especially the hematochezia, would manifest as a massive perirectal bleeding. Otherwise, the upper GI bleeding will manifest as a melena. So if this patient is having melena, so we can think about whether there is some sort of a upper GI component as well. Then you narrow down your diagnosis. Since this patient has a perirectal bleeding, it should be from the lower GI tract. So basically, I'm just telling about this, go for the proper diagnosis in the history. So if it is lower GI bleeding, then you have so many differentials. The way that I classified would not be the way that you classified, but I think if you could classify according to some sort of either anatomical or a pathological basis would be more palatable. So in pathology, the lower GI bleed, it could be either a congenital condition or some sort of a degenerative condition, just like some sort of an inflammatory bowel disease or some tuberculosis, or it could be some sort of an infective and inflammatory reason, or it could be a neoplastic reason, or it could be trauma. So I will tell it again. So in pathologically, whatever the pathological manifestation should under these 5 categories. Either it should be congenital. So it has been there since birth onwards. For an example, if the patient is having some sort of angiodysplastic symptoms, so he or she must be having this condition from childhood onwards sometimes. And the second one, whether it is a degenerative condition, right? So third one, whether it is infective or inflammatory condition. Fourth one, it could be neoplastic. The fifth one would be trauma. So those are the 5 pathological classification for whatever the pathological condition under the sun and moon. So since you mentioned it's a painless bleeding, so this bleeding should be in the lower GI section, and it should be above the dentate line. That is because if there's a bleeding which is below the dentate line, would manifest as a painful perirectal bleeding. So easily by telling this painless bleeding, you can exclude the pathologies which are below the dentate line, for an example, which is very unlikely to be due to the anal fissure or some sort of a perianal hematoma or a thrombosed hemorrhoid. So in that instance, so we narrow down our diagnosis to the lower GI, which should be above the dentate line. And the common things are common, and whatever the patient who is manifesting with the perirectal painless bleeding over 40 years of age, unless proven otherwise, our job is to exclude a rectal or a colorectal cancer. So that is our intention and that is our goal. This patient is 50 years of age. So the first differential diagnosis would be whether it is a colorectal cancer. But there are other diagnoses where you have to consider. Since you have mentioned about this inflammatory bowel disease, in the history, how do they manifest? So inflammatory bowel disease can manifest due to the GI symptoms as well as in extraintestinal symptoms. In GI symptoms, inflammatory bowel disease, it comes as intermittent. So you get some sort of a episode or a period of symptoms of perirectal bleeding, mucus discharge, cramping like pain, but it will settle with medication or again a manifestation with another relapse. So it should be in intermittent manner, which is not there in this history. So there is no intermittency at this history. So the inflammatory bowel disease would be more unlikely. Then I'm just discussing few differentials. Another place, the examiner might ask whether this is due to some sort of infective reasons. For an example, amoebiasis or some sort of inflammatory colitis. So that would be a manifestation, but in this history, which is 9 months duration history, so which is very unlikely to be the amoebiasis. That is because in amoebiasis, it transmitted with the toddy basically, or a fecal transmission, and patient might be experiencing other symptoms, just like some sort of a cramping pain with fever, and patient might be dehydrated, patient is having severe pain on the right hypochondria because of the hepatic abscesses, and it should be a very short duration history, again, which is very unlikely on this patient. Then you mentioned about the tuberculosis, and you have basically excluded the tuberculosis by telling this evening pyrexias, night sweats, and any contact history. And tuberculosis would be a manifestation of perirectal bleeding, which is very rare at this era. And thereafter, you mentioned about the inflammatory bowel disease, which I have already discussed with the intermittent nature. And in inflammatory bowel disease, sometimes it would be going with the families. And again, this patient had a family history of bowel malignancy, which is around more than 50 years of age, which is very significant. Sometimes you might think about this genetic predisposition on this patient, since it is a early manifestation. But early would be around 40s or 40s to 50s. But this patient is 50 years of age, which is very inconclusive whether it's early or a middle age. And the other common thing is hemorrhoids. Hemorrhoids usually they manifest as painless perirectal bleeding, but most of the cases in second degree or third degree, you might experience some sort of a lump, which is not there in your history, so which is again unlikely. And other benign conditions would be a Shigella dysentery, again, which is very unlikely at this moment, and your diverticular disease. Diverticular disease, though it is not that much common in our society, usually how they present is they get left iliac pain. That is because diverticular disease is more common in the sigmoid colon. They present with, again, another episodic presentation, left iliac pain with blood and mucus diarrhea. And sometimes they get this intermittent fever and malaise because of bacteria. They have gone beyond the gut mucosa, forming some abscess in between the mesenteries. So this diverticulitis is another presentation, another common presentation with rectal bleeding. And very rarely I have mentioned this angiodysplastic condition, angiodysplasia, which is more common in the right side rather than the left colon. Again, they might present with the massive rectal bleeding, and very rarely they might get this right iliac but usually they get this right iliac pain time to time, but it's a massive rectal bleeding because of the angiodysplasia. It's an abnormal vasculature in the ascending colon. So after excluding these differentials, we can just narrow down our diagnosis for a malignancy. That is because this patient, I have heard about that loss of weight and appetite. Has he had loss of weight and appetite? Hello, yeah. Has
Yes,
he
sir.
had, right,
Yes.
okay, loss of weight and loss of appetite. So why they get this loss of weight and loss of appetite? So if you consider about the loss of weight, basically the malignancy, it causes some tumor cachexia because malignant cells, they release these interferon, interleukins, and tumor necrosis factor. They basically catabolic interleukins. So they call tumor cachexia. So because of that, they lose some weight, and not even that, they are losing some blood time to time. So anemia itself, and the blood, it contains some sort of protein. So losing of the protein can give rise to loss of weight. Loss of appetite, again, because of most of the patients, those who have loss of appetite, there could be a component of liver metastasis. That is because liver is the place where you catabolize this appetite, either stimulants or suppressants, basically the orexins and leptins being secreted at the fundus of the gut. So if there's more leptin, it causes basically loosening of appetite. So that could be the rationale behind loss of appetite, or otherwise the tumor has been metastasized to the liver. So that is the symptom of distant metastasis. So after discussing this benign and the degenerative conditions, you can again narrow down your diagnosis for a rectal cancer or a colorectal cancer. So colorectal cancers, depending on the site of the pathology, they behave differently. For an example, if the colorectal cancer arising from the ascending colon or the cecum, how do they present? They don't give massive rectal bleeding, or the bleeding is very minimum. Sometimes it might go unnoticed. So how do they present then? So right-sided or a cecal malignancies, they present with painless right iliac mass with features of anemia, just like this exertional dyspnea, undue exertional dyspneas, and fluid type chest pain and shortness of breath with right iliac mass. If the tumor is basically arising from the transverse colon or the descending colon, usually you can see they pass blood with mixed with they pass feces which mixed with stool, mixed with blood. So in that instance, you can't see the frank blood, but blood mixed with stools. That is because proximal the tumor, it takes some time. Within that time period, the blood already mixed with stools. So they pass blood with blood which has mixed with the stools. And tumors in the descending colon manifest as the bowel obstruction. That is because, when compared to the right side colonic tumors and the left-sided colonic tumors has an annular development. So basically, they go along the lymphatic channels along which is an annular deposition. So because of that, the tumor is basically growing all around the circumference of the bowel. So at the end of the day, this narrowing of the circumference of the bowel, they present with bowel obstruction. So that's why the books, most of the articles, they describe the left colonic cancers, they present as bowel obstruction. The cardinal features of bowel obstructions are abdominal distension, colic abdominal pain, absolute constipation with vomiting. So left-sided colonic cancers, they present with blood which mixed with stools and features of bowel obstruction. Then you go downstairs, especially the sigmoid colonic one. Again, you can see the blood mixed with stools, but it has more brighter in color. That is because which is very closer to the rectum, so it does not have that much of time to alter the blood. So if the tumor is more close to the rectum, they get more fresh red color blood when compared to the tumors in this the upper descending colon or the sigmoid colon, where during that period blood can be altered. So if it is sigmoid colon, you can see the blood which is very bright in color. And if the tumor is lower down, especially in the rectum, so the main presentation, as you all have mentioned, it's a rectal bleeding. Sometimes we might mix, but there's a very fresh, massive rectal bleeding can be experienced. So if it is lower down, the blood is the fresh blood. And since the tumor is in the rectum, they might get other symptoms, just like you have mentioned about this tenesmus. So in the exam, most of the time, if you say tenesmus, they will ask definition, what do you mean by a tenesmus? So tenesmus is a painful desire to open the bowel, but without producing any fecal matter. So why you get the tenesmus in a rectal cancer? That is because the rectum is one of the distended part in the lower GI tract. So if there's a tumor occupying inside the rectum, the brain, there's the physiologically there's a defecation reflex. So brain get the impulse that there's some sort of fecal matter or some sort of space occupying the lesion inside the rectum. So if the rectum get that sensation, your defecation reflex get activated. So they try to expel the content inside the rectum, which cannot be. That is because it's a rectal tumor. So it causes spasmodic contraction. So they get the tenesmus because of these contractions, but they could not expel the tumor. So that's why in tenesmus, it's a painful contraction without producing any fecal matter. So that is one characteristic symptom in rectal cancer. And they get sense of incomplete evacuation. That's because once they go to the toilet, they expel whatever the fecal matter. But again, there's some sort of a rectal cancer that has been there inside the rectum that you could not expel it because it's firmly adherent. So that's why they get this sense of incomplete evacuation. And not even that, these rectal cancers are basically, the malignancies arising from the mucosa. Especially in the large bowel, they are adenocarcinomas. So they are arising from the secretory epithelium. So in large bowel, the mucosa comprise of a lot of mucus secreting globular cells. So what happens is, if it is a rectal cancer, the proliferation is not coordinated. They secrete more and more and more and mucus. So this mucus basically mixed with blood. So that's why they get blood and mucus diarrhea, or passing of mucus with blood. If it is a rectal cancer, it produces more and more mucus. So that is more characteristic in a typical rectal cancer. So that is one way of presentation in a rectal cancer. It's a blood and mucus diarrhea. And you mentioned about this early morning spurious diarrhea. Why they get early morning spurious diarrhea? So that is another characteristic symptom. So usually the patient goes to the toilet in the morning. That's what we practice in day-to-day life. So if the sphincters are intact, so what happens is the cancer secrete more and more mucus because it's contain a lot of mucus secreting globular cells, and this mucus basically mixed with the stools. So what happens is the mucus mixed stools, it will become some sort of a jelly-like material, and once they go to the toilet, it passes the liquefied fecal matter that has been mixed with the mucus. So that's why they get spurious diarrhea. And since you are going to the toilet in the morning, you get spurious diarrhea in the morning. So whatever the fecal matter that has been accumulated inside the rectum mixed with stools, and you open up. So they get early morning spurious diarrhea. It's one of the characteristic or a typical presentation. But if you are saying so, if they have early morning spurious diarrhea, which means you didn't have any diarrhea during the daytime. What is the importance of that? If a patient is having spurious diarrhea throughout the day, which means there's some sort of an incontinence. That's because they could not control it, which means the tumor has gone into the anal sphincter. So that makes the difference or a demarcation between whether this patient need a anterior resection, or basically it's a tumor confined to the rectum, you need a anterior resection. If the tumor does not confine to the rectum, which has gone beyond the rectal mucosa into the anal sphincters, you need an abdominoperineal resection. So in the history, if the patient is having early morning, the spurious diarrhea throughout the day, which means the sphincters has gone. So that's why you mentioned about this fecal soiling. So fecal soiling, again, a way of presenting some sort of a sphincter involvement. So that is important in the history. So by listening to the patient, you can judge, you can get an idea whether this tumor has confined to the rectum or whether it has gone beyond the rectum into the sphincters. So that change your management. And so those are the symptoms which are relevant to the rectal cancers. And not even that, there are symptoms that will manifest because of the local advancement of the tumor as well as distance metastasis, which I don't want to discuss about the distance metastasis. That's because you have nicely discussed about this the presentation due to the bone mets, presentation due to the liver mets, or the lung mets, or the brain mets. And I would like to discuss a little bit more about the local advancement of the tumor. So if you want to get an idea about the local advancement of the tumor, always think about the anatomy. In males, you know, there's the bladder and the prostate, which is anterior to the rectum. In females, there's the vagina and the uterus, as well as the bladder further in front. So if the tumor spread anteriorly, what happens is it can grow into the bladder. So ultimately end up in the rectovesical fistula. So how do they present in the rectovesical fistula? Basically, pressure gradient is towards the rectum to the bladder. So patient might pass fecal urea. So he complains, I have passed stools with some sort of a sediment, and not even that, which is very floppy and which is foul smelling. And sometimes the patient might experience there is no continuous flow because there's some pneumaturia, gas entering into the bladder. So they get intermittent flow and fecal urea. So that is because of the anterior extension of the tumor into the bladder. If the tumor has gone posteriorly, what happened? Again, think about the anatomy of the posterior to the rectum. So that is the presacral fascia and the presacral, the sacral plexus. So if the tumor gone into the sacrum, that erode or invade into the nerve plexus, so they get intractable, basically the lower back pain. And if the tumor has gone laterally, what are the lateral structures? Those are the ureters basically and the pelvic floor. So they get strictures and they get recurrent urinary tract infections. So those are the manifestation of extension laterally, anteriorly, and posteriorly. And not even that, tumor can spread lower down. So I mentioned in the rectal cancer, which has gone beyond the rectum into the anal or the pelvic floor and everything, you get the sphincter involvement. So that changes your management, as I told you earlier. So if the tumor invade the sphincters, so they present with if the internal sphincter, so especially these sphincters, there are two components. One is the internal sphincter, the other one is the external sphincter. So internal sphincter is some sort of a autonomic control. So that controls the flatus. So that has the ability to control the flatus. External sphincter, basically, it has a somatic control where you can control it by yourself. And if the external sphincter being invaded, your somatic control will lose. So the patient could not control the bowel opening, so he get fecal soiling and continuous flow into the exterior. But if the tumor involved only the internal sphincter, you get only the flatus incontinence, not the fecal incontinence. But if the external sphincter has gone, they get the fecal incontinence as well. So those are the manifestation of the rectal cancer that has gone down. So then you think about in the history, basically we consider 5 components. So first thing, your introduction that everybody they have to start with. Then you tell about the presenting complaint and the history of presenting complaint. So that you have nicely discussed. And then you think about the etiological component, and the fourth one would be the complications, and fifth one would be the fitness for the surgery. So in etiology, the rectal cancers, as you mentioned, the people those who consume a lot of red meat, there's a high chance. And those who are smokers and alcoholism, again, there's a chance for the rectal cancer. And not even that, this genomic predisposition. So in genomic predisposition for the rectal cancer, you should not forget about this familial adenomatous polyposis coli. So there the patient get multiple polyps, more than 100 polyps in the large bowel. Usually they manifest before the age of 30 or very early manifestation. They get this rectal bleeding. Once you put the scope, you can see more than 100 polyps. That itself, it is diagnostic. That is called familial adenomatous polyposis coli because of the genomic instability in the tumor suppressor gene. There's a FAP beta-catenin, right? Then there's another genomic predisposition in colorectal cancer, that is hereditary non-polyposis coli. So they do not have any polyps, but there's a chance of getting malignancies. So the problem is there's a mismatch repair genomic instability. So they get HNPCC. So how do you diagnose HNPCC? So it's like 3 to 1 0. So 3 family members, 2 consecutive generations. One would be less than 45. Some books says 50s, and the fourth one would be you have to exclude the familial adenomatous polyposis coli, and not even that, these Gardner syndromes, Turcot's, and so on and so forth can give rise to colorectal cancers, and Lynch syndrome, especially the young people, and P53 mutations can give rise to colorectal cancers. Just touch on them. That must be beneficial in your MCQs as well. So you have to get some history with regards to any endoscopic procedures, any family history of polypoids, or family history of early rectal cancers would be genetically predisposed. And so those are the etiological reasons. And very rarely the people who underwent a laparoscopic cholecystectomy can get a chance of getting colorectal cancer, but those things are very, very rare. But if you can just discuss the important major components, that would be enough. And so those are the etiological components. And the complications that we have already discussed about the distant metastasis and the local advancement. And the assessment for the fitness, again, I usually ask about this: diabetes, high blood pressure, heart disease, and bronchial asthma, and any allergies to food or drug or plasters, and whether the patient is on any blood thinners. That is because If the patient is on blood thinners, you have to optimize him, or you have to bridge him for some sort of surgical intervention. So once you have concluded your history, so you can give us a differential diagnosis. So unless proven otherwise, this patient is having a rectal cancer, as you have mentioned. He has all the symptoms with loss of weight and loss of appetite, which is most suggestive of malignant transformation. And then we'll discuss about the management. So once you go and you get 5 minutes to discuss about your plan. Basically, you have summarized is 90, that's good. And once you start with the summary, the examiner might start asking questions in order to discuss, to get the idea about your management plan. So the common questions will be asked in the exam is, so what do you want to do if you get a patient with perirectal bleeding? So you can start, I would like to confirm my diagnosis by doing some endoscopic procedures. And once I confirm the diagnosis, I would like to stage the disease and assess the fitness for surgery. So that would be your opening statement. So how do you confirm the diagnosis? That means, in that instance, first of all, you can plan for a flexible sigmoidoscopy. Examiner might ask, why don't you do a colonoscopy instead of a flexible sigmoidoscopy? The answer would be sometimes it could be almost obstructing lesion. If you try to prepare the bowel straight away without getting an idea, you will end up in a bowel perforation or a bowel obstruction. So it's better to do a flexible sigmoidoscopy after inserting enema, and same time you can get some biopsies. And you can assess the lumen, whether this patient is fit enough to undergo a colonoscopy after proper bowel preparation. If the tumor is completely obstructing the lumen, so there is no place for colonoscopy on this patient. So it's better to do a flexible sigmoidoscopy. Then the examiner might ask, how do you do a flexible sigmoidoscopy? Only thing that you need is patient needs 6 hours fasting and enema. Right, even enema would be enough to do a flexible sigmoidoscopy. And they ask about this, what would be the size of the flexible sigmoidoscopy, which is 70 centimeter in length. But most of the places where you use the colonoscope, which is 160 centimeter in length. So if the tumor is not completely obstructing the bowel, where you can plan for a secondary colonoscopy to assess the synchronous lesion, which is around 4.8. Some books say which is 2.5, whatever, it should be less than 5% among the population, to see whether the patient is having synchronous lesions. And you do a flexible sigmoidoscopy, take multiple biopsies, at least 6 biopsies. That is because you have experience. Sometimes if you take a biopsy and send it, they give you the report as high-grade dysplasia, which exclude the malignancy. So in that instance, you can go further. So sometimes you have to do some repeated biopsies. So it's better to get adequate number of biopsies, not from the center, get it from the peripheries and get some deep biopsies. So hopefully once you send this specimen for the histology, it take around 12 to 14 days. And you get the report of adenocarcinoma. Most of the time, it should be moderate different adenocarcinoma. So that is for the diagnosis. Then they will ask, how do you stage the disease? So staging the disease would comprise 2 things, either the local staging as well as distance metastasis. So it's better to do a contrast enhanced CT, chest, abdomen, and pelvis to see lung mets or a liver mets or a bone mets, or and that will give you some sort of a local advancement of the tumor. But especially the rectal cancers, it is better to do a pelvic MRI with rectal endocoil to assess the local advancement of the tumor. So pelvic MRI would be the number 1 to assess the local advancement of the tumor, especially whether the tumor is invading into the presacral, the mesorectal fascia, whether it has gone beyond or whether it has confined into the mesorectal fascia. So that is delineated, that is basically identified by doing a pelvic MRI. And the CT scan to assess the distance metastasis basically. So if somebody asks you how to stage, ideally you have to do the both contrast and CT, chest, abdomen, and pelvis, and the pelvic MRI with rectal endocoil. So once you have done it, you have already staged the disease. So then they will ask about the plan. So what do you want to do? So once you have done your staging, you stage the disease and you confirm the diagnosis, then the next step would be you have to discuss it in the multidisciplinary meeting where you get together and you discuss the best management plan for this particular patient. So especially this multidisciplinary team consists of a surgeon, those who have diagnosed this patient, and your oncologist should be there. So that is because some patients you have to give neoadjuvant, short course or a long course, and your radiologist would be there to give you the idea about the stage of the disease, and your pathologist have to be there. That is because he's the guy who is telling about the pathological subtypes, right? Whether this patient is having a very aggressive tumor. For an example, if the tumor is having more mucinous components, so or neurovascular involvement, so it is a more aggressive tumor. So likewise, so you get different inputs from the pathologist, and the stomach care nurse should be there. So she's the lady, she declared about this stoma and how to maintain it, and the discussions has to be carried out with the stomach care nurse. So likewise, there's a team that is called the multidisciplinary team, where at the end of the day you discuss and give them a proper management plan. And in general, it's a healthy, fit individual. If it's an early tumor, you can give the short course. If it's a little bit of advanced T3, T4, where you can give a long course of neoadjuvant. That is because why the people they use this neoadjuvant. The importance of giving neoadjuvant is to minimize the local recurrence, nothing else. So it does not give any survival advantage because of the distance is made. That basically minimize the local recurrence. And by giving neoadjuvant, your local recurrence can be minimized by 30 to 40%. So it's a statistically significant amount. So neoadjuvant for rectal cancer is mandatory unless the patient is a very fragile, feeble patient, those who could not go for neoadjuvant. If you need to get rid of the tumor, then there's a place for some sort of a endoscopy mucosal or some sort of a natural orifice surgeries. But basically, in general, the rectal cancers, it's better to give neoadjuvant. If you think about the neoadjuvant short course, what they do is they give short course of radiotherapy around 2 grays per cycle for 5 days, and you start the resection on the next week. So that is called the short course. So if it's a very early tumor, T1, T2, better to give a short course of radiotherapy, and then you take the patient with it on the following week on Monday and go ahead and take the rectum out, or that is called the anti-resection. And if it is a T3 or T4 tumor, basically that's threatened to the mesorectum. So it's always you need to give neoadjuvant long course. So in long course, usually you give a chemotherapy, then followed by a radiotherapy, and then other chemotherapy. It's like a sandwich. So you give radiotherapy in between 2 chemotherapeutic sessions. So once you have given this long course of neoadjuvant, you can't just say that I'm going to operate on that. You need to give some time. Why? We have to give some time. You know, once the patient is exposed to the neoadjuvant chemoradiation, what happens is these tumor cells is become shrunken because of the apoptosis. So once the cells being exposed to the radiation, so they start apoptosis. So it takes some time to shrink the tumor. So book says around 6 weeks. So ideally it has to, we have to wait at least minimum of 6 weeks to get it shrunken. So then we can embark on an anterior resection. So if for an example, if the patient has given long course of chemo radio, you have to wait 6 weeks prior to surgery. And the other thing is, if you keep the patient more lengthier time, you get a lot of fibrosis, and it is basically more hectic to the surgeon. So it's better to operate after 6 weeks. Just after 6 weeks would be the best. So keep it in your mind. In rectal cancers, there's a place for neoadjuvant, either short course or a long course. In short course, you need surgery just after the short course of 1 week of radiotherapy. But in long course, you have to give him 6 weeks period in between surgery and the conclusion of neoadjuvant to get the tumor to be apoptosed and shrunken and becoming the lesser in volume. So that's how you plan for a surgery. So thereafter you do a anti-resection for rectal cancer. If the rectal cancer has gone into the anus or the sphincters, patient need a abdominoperineal resection, that is called the APR. Anti-resection, you make it as a AR, that's anti-resection. So those are the two options for rectal cancer, which has confined to the rectum or which has gone beyond the beyond into the anal sphincters. And people who are having the left-sided colonic cancers, left hemicolectomy, or if the patient is coming with some obstruction, then there's an extended right hemi. And if the patient who are having a sigmoid colon cancer, you can do a sigmoid colectomy, where you take the tumor out. You can do left colectomy, that is called left colectomy. Would not give the proper treatment for that patient. That's because it's already obstructed bowel. So you have to take the already distended, obstructed ischemic part out. So in that instance, you have to do the extended right hemicolectomy. So basically keep it in mind. If it is on the right side, you do right hemicolectomy, left side, left hemicolectomy. And in the sigmoid colon, you do the sigmoid colectomy. If it is in the rectum, you do the anti-resection. If it has gone beyond the rectum into the anal, you do the abdominoperineal resection. So performing these procedures, the ideal is to laparoscopic or robotic, which is not available, but we do laparoscopic anti-resection or abdominoperineal resection or a sigmoid colectomy or a colectomies, depending on the site. So that would be the gold standard of management. So for that, the patient need to be optimized before you embark on operation. So main optimizing parameters are patient's protein. That is because you do anastomosis. So if the protein is low, hydrostatic pressure is maintaining and your oncotic pressure cannot be maintained. So you get a lot of edema. So that will end up in anastomotic lesion. So first thing is to maintain the protein. The second one is to maintain the adequate amount of hemoglobin. That is because hemoglobin carries the oxygen into the anastomotic site, so that facilitates the wound healing. So your patient's hemoglobin and the protein should be corrected before you embark on a major surgery, in addition to his cardiac, respiratory, and renal functions. So once the patient is operated, if it's a lower rectal cancer, you need to put a protecting ileostomy as well if you are going for the primary anastomosis. But with our experience, if you have done proper dissection, it's better. You can just go ahead with anastomosis, especially on the lower rectum. Other anastomosis can be done without having any protecting ileostomies. So you'll have seen how do they perform. They use these circular guns that passes from the backside in the rectum into the rectum through the anus, and they use TA guns. So sometimes with reality they might ask what equipment that they have used. So TA gun is for the rectal dissection at the lower end, then circular guns for the circular anastomosis to maintain the continuity of the bowel. And so those are the options. And I initially mentioned about this familial adenomatous polyposis coli. The treatment is you do a total proctocolectomy and ileoanal anastomosis, or ileal pouch and anal anastomosis. So once you have done the surgery, you follow the patient in your clinic. So once the patient fully recovered, how do you follow up? So where you have to do the CEA, that is the carcinoembryonic angina, though it is non-specific, that will help you for the proper follow-up. It's better to do a CEA level before you embark on operation. That is because that will give you the basal level of carcinoembryonic antigen that is useful in follow-up, in following up the patient. So you do carcinoembryonic antigen CEA levels every 3 months for the first 1 year, and the second year you do in every 6 months. So at the end of the first year, you do a contrast and CT to see whether the patient is having any synchronous lesions or any other pathologies. And at the end of the 2 years, you do a proper colonoscopy again to exclude whether the patient has any local recurrence or whether the patient has synchronous lesion that you have missed in the past. So after 2 years, you do yearly CEA for 5 years, basically 3 more tests, and finishes off if the patient does not have any alteration of the CEA level. So I'll summarize it again. So in the post-operative plan or a follow-up plan, you do CEA every 3 months before the first year, every 6 months before the second year. From third year onwards, you do annual CEA once a year. And at the end of the first year, you do a contrast and CT to see whether the patient is having distant metastasis or the recurrence of the disease. And at the end of the 2 years, you do a colonoscopy. So that's how you manage the post-operative patient and the post-operative follow-up. And so I just summarized this colorectal cancer management. So you stage the disease with your, after confirming your diagnosis with the flexible sigmoidoscopy and colonoscopy with MRI and the CT. Once you have staged, you discuss in the multidisciplinary meeting, and most of the time you have to give neoadjuvant, downgrade the tumor, as well as main important things to minimize the local recurrence. Then you have to plan for a laparoscopic colorectal surgery. So I think that would be the nutshell of colorectal cancer management. And do you have any other questions, please?
Actually, very nice, comprehensive discussion. Do that he explained nicely about how to take history, what are the differential diagnoses, then how to analyze, how to narrow down your diagnosis to the provisional diagnosis, then how you investigate, then that's the basic principles that you should know to how to manage this kind of condition. Yeah, if you have a question, you can ask directly, then he will discuss with you.
Okay, if you are reluctant, you can just either email it to me or you can just WhatsApp it to me.
Sir?
We are happy that if you can ask directly. It's
right.
not that I can read some questions there in that chat box. Yeah.
Excuse me, sir, what about total neoadjuvant therapy for the locally advanced rectal carcinoma?
That is mandatory. In locally advanced rectal cancer, so our intention of giving this neoadjuvant is to minimize the local recurrence. So that is the only indication. So if it is locally advanced, if you are given the long course of neoadjuvant, so that will, most of the time that will downgrade the tumor. But there are instances the tumors are not responded to the neoadjuvant. In that instance, I don't think that will give a benefit, but generally, yes, if you give local, if it's locally advanced tumor, if you are given neoadjuvant treatment, it will most of the time it will downgrade where you can minimize the local recurrence. So it should be a long course.
So then also for early rectal carcinoma, is it a must to do the short course radiotherapy or can we go straight to the surgery?
So it's all depend on the patient's the other factors. Imagine that if the patient is around 85 years of age, very fragile. So that instance, if you just try with this radiotherapy, sometimes you don't get that much of a benefit. So in that instance, it's better to take the tumor out unless basically it's all depend on these three factors. First thing, the patient factors, the other one is the environmental factors, and the third one would be the tumor factors. As I mentioned, if it's 8 years of age, if the patient is fit enough to undergo surgery, if you think about taking the tumor out without giving neoadjuvant short course, that would be better. That is because 8 years of age patient, are you expecting him to be alive for another 20, 30 years? And rather than just wasting time, so it's better to go ahead with the resection. But very rarely, though we don't have the exact facilities, there's a place for if it's a tumor T1, if it is below the peritoneal reflection, I think you have heard about this natural orifice transluminal endoscopic nodes. So where there's a device where it passes through the anal canal and widen up, and you do a mucosal resection. That does not need any general anesthesia. That does not need any neoadjuvant radiotherapy, and you take the tumor out if it is T1. If it is below the peritoneal reflection, so that would be the ideal for that kind of a debilitated patient with a lot of comorbidities. But otherwise, giving short course, you have to consider. That is because most of the people, they might think that if you are given this radiotherapy, they get the other manifestations. So if the patient is fit enough, if irrespective of the age, it's better to give at least a short course for a early tumor. But if the patient is not fit enough, if it's an early tumor, better to do the nodes where you endoscopic mucosal resection would be the best, provided the patient's physiological states are being already deranged.
Thank you, sir.
Did I answer your question? So if you can just tell me the patient's age and the other comments where you can tailor your management. There is no hard and fast rule that this would be the best management. It's all depend on mainly on the patient factors. For an example, if you have taken a biopsy if you have taken the biopsy already, and if it has lymphovascular invasion, in that instance, your resection margin would be minimum of 2 centimeters. If the patient does not have lymphovascular invasion, even 1 centimeter resection margin would be enough. So there's a component from the pathological part as well. So it's a multi-component decision ultimately.
Yes, sir. Thank you, sir.
Okay.
Sir,
I
if there's
can, yeah.
sorry, sir. So if there's a metastatic colorectal or rectal carcinoma, sir, then do we still have to do any resections or surgeries to the colon?
Yeah. So metastatic colorectal cancer, even if it has metastasis to the liver, which is resectable. For an example, patient is having a rectal cancer with the left lobe metastasis, segment 1, 2, 3, 4. So you consider it as a curable disease. That is because you can take that left lobe out and you can take the rectal tumor out. So you consider as a resectable tumor. And colorectal cancer with lung mets, again, if it is resectable, you can consider it as in a curative resection. Basically, rectal cancer with lung mets or liver mets, which is resectable, you consider it as a curative resection. You can treat the patient completely. So, but if it has gone into the brain or the bone, you consider it as a incurable disease. And in that instance, there is no place for anti-resection. In that instance, only option is you can do some sort of a defunctioning colostomy. That is because if the rectal cancer is almost impending obstruction, you have to get rid of the obstruction, either making a stoma or a Hartmann's procedure. But it's better to make a stoma without doing any massive operation, since it's an incurable disease, since it has gone beyond the liver and the lung. But if the tumor, colorectal cancer gone into the liver or the lung, which is resectable, you consider as a curative surgery where you have to do the anti-resection. But if it has gone beyond that, it's an incurable disease. There is no point of taking the tumor out. You do a defunctioning colostomy to prevent the patient going into a bowel obstruction.
Thank you, sir.
Right.
There are few questions appearing in the chat box.
Hmm.
Is it okay, Vidu? Can I ask?
Of course, no. That's all
Okay,
right.
right. Then how can we do? What about the total neoadjuvant therapy? I think he's asking about TNT or something. I don't think we are practicing here now. Not
Yeah,
yet started.
no,
Yeah.
the problem is the total neoadjuvant. I have seen a couple of patients, those who have been 100% responded to the treatment, especially the people who are more having a lot of other comorbidities, the debilitated patients. The total neoadjuvant therapy would be enough. For an example, 75 years of age, 100% response, that would be enough. But we are not practicing here. What we practice is you proceed with the initial plan that you have made at the time of the MDT. So you plan for a neoadjuvant, you have already given the plan for anti-resection. Though if it has 100% responded, still you have to do the anti-resection. That is our practice.
Next one. So, how can we differentiate solitary rectal ulcer from colorectal cancer?
So very easy. It's only the biopsies. So once you do in history, it's more or less equal to the rectal cancer. You do the examination, you can get some sort of coliform-like appearance, but their center. So again, you won't be able to differentiate. But only way is you do a histological assessment that will give you the diagnosis. It's a chronic inflammatory tissue without having atypical cells. So that is the presentation of the solitary rectal ulcer, though it presents as a malignant disease. Only the histological diagnosis would differentiate rectal ulcer from the malignancy. And even the CT scan, MRI, you can see some sort of indurations, local inflammation, but only the histology would do the job.
There's another one. I can't understand it. What are the post-op complications specific to these surgeries?
So if somebody asks you about the post-op complications, so in a medical student level, so you say about these anesthetic complications and the surgical complications, but forget about these anesthetics. So the surgical complications are initially the early, late, and delayed complications. So early complications, because of the pain and everything, they get this atelectasis. And the most important complication is the anastomotic leakage. Usually they present after day 4, day 5. So usually present at day 5, but from day 4 onwards, patient get other symptoms. Patient gets some sort of a fever, the pyrexia, and you examine the patient. There's some sort of tenderness in the abdomen, and these parameters are basically not in the physiological status from the beginning onwards. So if that's how you anticipate. Though you don't need to wait for the day 5, but from the beginning onwards, his parameters are not in the standard manner. So it might fluctuate. So day 5, you get the patient is fever on examination, the abdomen is peritonitic. So it is one of your differential. It's anastomotic leakage. And not even that, the wound lesions, some sort of the wound infections, because your contaminated material is taken through the skin, and urinary tract infections, and the atelectasia and the pneumonia because the pain patient preclude from taking deep breath, and later the prolonged bed redundancy can give rise to DVT and pulmonary embolism. So just to summarize, patient can get immediately the atelectasis. Thereafter, you might get pneumonia, urinary tract infections, wound infections, wound lesions, anastomotic leakage, and deep vein thrombosis and pulmonary embolism. So those are the common complications just after the surgery. And later, the patient in delayed complication, patient might get local recurrences or distance metastasis. That is because you have heard about this anastomotic, the metastatic signature, different cells, they behave differently. And stricture formations, another bowel obstruction, or the recurrence of the disease are late complications.
Considering the time, I think that I have to answer one question. It says that, so how we ask about spurious diarrhea from patient in history taking?
So in Sinhalese you can ask, උදේ පාන්දර නැගිට්ටාම බඩ බුරුල්ලට ගහගෙන යනවද? So that is because that mucus and a lot of the liquidized fecal matter, as well as the ongoing bacteria that cause some sort of fermentations and that cause some liquidization, all together contribute to this early morning spurious diarrhea. උදේ පාන්දර නැගිටපු ගමන් toilet එකට යනකොට බඩ ගහගෙන ගියාද? ඕ බුරුල්ලට ගියාද වතුර වගේ. So that's how you ask.
Now, is it down south accent, Vidu?
Sorry?
Is it down south accent?
I think that is down south.
Okay. Okay, thank you very much. Actually, that
And extremely my apologies for delayed starting business. That's why I just a little bit late today.
okay, that I hope that you will support our exam next time this year.
Okay.
Right. Okay. Thank you very much. I have a message tomorrow. Dr. Anuradha Jayatilaka will discuss. It's a kind of interactive session at 8 p.m. tomorrow. I think it's the 5th webinar that you can join. Then I think it's the time to say good night. Okay. Good night, Vidu. Thank you very much.
Okay. Thanks. Okay. Bye-bye.
Thank you, sir.
Thank you, sir.